We'll finish up by taking a closer look at another respiratory illness, tuberculosis. This is an overview of the pathogen and the disease. It's been with us for a long time, and even today, it's still a major infectious disease threat. It infects about 1/3 of the world's population, but you will see that the disease disproportionately impacts certain people in certain areas of the world. The classic symptoms of an active tuberculosis infection are chronic cough, traces of blood in the sputum, fever, night sweats, and weight loss. And while the infection usually begins in the lungs, it can spread, and this can lead to a wide range of signs and symptoms. We can usually treat tuberculosis, but treatment does take a very long time. Tuberculosis is an ancient disease, and there's been evidence of tuberculosis found even in things like Egyptian mummies. There are many different species that have the ability to cause tuberculosis in humans. We'll mostly be focusing on Mycobacterium tuberculosis, but please be aware that Mycobacterium bovis and Mycobacterium avium can also cause disease. Bovine tuberculosis, which is caused by Mycobacterium bovis, infects cattle and can sometimes infect humans. In the past, before pasteurization of milk, many people were made ill by consuming contaminated milk. In places where pasteurized milk is sold, this type of infection is pretty rare. People with HIV are much more likely to contract tuberculosis from these species than the average person. Looking at what happens in primary tuberculosis infection, we have a known series of events that usually occur. The bacteria are inhaled in respiratory droplets from people who are infected. These droplets are extremely small, and they can travel further, reaching the alveoli. White blood cells called macrophages engulf the bacteria, but unlike what they do with most bacteria, they are not able to kill Mycobacterium tuberculosis cells. These bacteria inhibit the fusion of the lysosomes to the endocytic vesicles that contain the bacteria. The bacteria are able to replicate inside the macrophages, gradually killing these cells. The immune system of a person who's infected ends up sending more macrophages to the site, and this also ends up with a bunch more macrophages becoming infected. In addition to those macrophages being recruited to this area, inflammation is triggered. A tubercle starts to form as tightly packed macrophages surround the site of infection, and this usually happens over a 2 to 3 month period. Collagen fibers are deposited, and these enclose the infected macrophages and lung cells. The cells at the center end up dying, and they release Mycobacterium tuberculosis bacteria, and the abnormal cell death that occurs inside the tubercle looks kind of soft and white, which gives it the name of caseous necrosis because it kind of looks like cheese. At this point, there can be a stalemate between the host, the immune defenses, and Mycobacterium tuberculosis. The bacteria can remain dormant for very long periods of time. The tubercles can become calcified, or granulomas can be formed, and these are associated with lower risk of progression to active TB. Secondary or reactivated tuberculosis can occur later when the tubercle is ruptured and bacteria reestablish an active infection. This happens in about 10% of patients. The risk factors for this type of tuberculosis usually relate to immune system changes, such as progression to AIDS, drug or alcohol abuse, poor nutrition, and things like this. If macrophages containing Mycobacterium tuberculosis travel through the blood or the lymph to other parts of the body, infections can become established in things like the bone marrow, spleen, liver, kidneys, spinal cord, or even the brain. This is disseminated or miliary TB, and as you might imagine, this can lead to some dangerous complications. The risk of developing tuberculosis is much, much higher in individuals who are infected with HIV than those who aren't. It's estimated that at least 1/3 of HIV positive individuals are living with TB, and right now tuberculosis is the leading cause of death in individuals who are HIV positive. These are sometimes called co-epidemics. Surprisingly, Mycobacterium tuberculosis doesn't really have a lot of virulence factors. The major ones appear to be involved in evading the immune system, so living in macrophages. The bacteria have specialized mechanisms for entry, can grow intracellularly, and are able to inhibit fusion with the lysosomes and phagosomes. They also have mechanisms to detoxify the oxygen radicals that form during phagocytosis, and normally these would be quite dangerous for a bacterium living inside the cell. In Canada and the United States, individuals are in high priority groups for TB testing if they're at higher risk of exposure or infection by TB, or if they're considered to be at risk for TB disease once infected. So in the first group, people who work in healthcare would fall into this group, and individuals who are HIV positive would fall into the second group. There are different methods that can be used to help with diagnosis. We'll talk about a few of these. A common test for tuberculosis is the tuberculin skin test, which is also known as the Mantoux test or the PPD test. Tuberculin is an extract of the bacteria, which contains a mixture of antigens. And antigens are the surface proteins that are present on the bacteria, which the immune system can recognize and react to if it's been exposed to it before. Tuberculin is injected intradermally, and after 48 or 72 hours, the person comes back to have the site observed. If the person reacts, then there'll be a raised, hardened area at the ejection site, and the diameter can be measured. Only the raised area is measured, so even if there's redness that surrounds that area, that is not included in the measurement. Just because somebody reacts doesn't necessarily mean they have tuberculosis. There are actually risk groups that will indicate what values would indicate an infection. So people who are considered to be low risk would have to have at least a 15 millimeter diameter for a positive result. There are some potential problems with the tuberculin skin test, and these include the possibility of false positive and false negative reactions. One thing to note is if somebody has had tuberculosis in the past, even if it was successfully treated, they are very likely to test positive with this test. Another possible false positive can happen if somebody was vaccinated with the BCG vaccine. BCG stands for Bacille Calmette Guerin, and this is a live attenuated vaccine, which means it includes live bacteria that don't normally cause severe illness in somebody when they're injected. This vaccine is fairly effective against the disseminated form of tuberculosis in children. It's less effective in adults, and because it is a live vaccine, there is the rare risk of infection in people who have suppressed immune systems. In parts of the world where TB is more common, the vaccine is often used for children. In Canada, the United States, and most of the United Kingdom, it's used very rarely, usually only for people at high risk. The interference of this vaccine with the skin test is a downside in regions where TB is at very low prevalence. Another potential issue is that immune responses can decrease over time but be boosted by the test. If somebody was exposed to the bacteria, many years later they may test negative, but then on the next skin test, they would test positive without actually having developed tuberculosis during that time. The two-step test for tuberculosis is now often done for people who have to get regular tuberculin skin tests. This shows in the flowchart what would happen when somebody has their first test. If somebody tests negative after going through the two-step test for tuberculosis, later tests only have to be one step. Chest x-rays may allow tubercles in the lungs to be observed. Primary tuberculosis is usually seen in lower and central regions of the lung, while secondary tuberculosis would usually appear higher. So chest x-rays often follow a positive skin test. Another immunological type of test that can be done for TB is the interferon gamma release assay. White blood cells from most people infected with Mycobacterium tuberculosis release interferon gamma when they're mixed with TB antigens, and this can be detected in this type of assay. The assay can be done using patient blood samples and is quite rapid, with results usually available within 24 hours. It only requires a single visit, unlike the tuberculin skin test. It's not affected by BCG vaccination and does not boost responses to subsequent tests. On the downside, it is expensive, and samples have to be handled and processed carefully to make sure that the white blood cells are alive for the test. These tests also don't distinguish between active or latent TB, nor even people who previously had TB that was successfully treated. It's quite challenging and very slow to culture mycobacteria in the lab. The generation time of this bacterium is extremely long. It's a very slow-growing organism. This probably contributes to the nature of the disease itself. We do culture Mycobacterium tuberculosis if you want to be sure that somebody has an active infection. While this is very time-consuming, it's necessary usually to be able to determine whether or not the strain in a patient is susceptible to particular antimicrobial drugs. Sputum samples can be taken from patients to look for the actual bacteria. Now, it should be noted that it's actually quite challenging and very, very slow to culture mycobacteria in the lab, but it is possible. The generation time of these bacteria is extremely long, and this slow-growing nature probably contributes to some aspects of the disease itself. Unfortunately, it can take weeks to get a good culture. This is usually a necessary step, though, to be absolutely sure that somebody has active TB and also to do antimicrobial drug sensitivity testing. Sputum smears can reveal actual living bacteria right away, and you actually see them as red stained cells after using this stain. They do quite often grow in these clumps, which is called corded growth, and this type of growth is a result of a particular glycolipid called cord factor, which is present in virulent strains of the bacteria and is involved in avoiding the immune system of the host. In introductory microbiology, we looked at the Gram stain, which is the most commonly used differential stain for identifying bacteria. The Gram stain allows us to distinguish between different types of bacteria based on differences in their cell walls, which affect whether or not they'll be able to keep the primary stain, which is crystal violet. Mycobacterial cell walls contain mycolic acids, and this is a waxy lipid that makes it very difficult to stain them using most traditional stains. It also makes them quite resistant to many environmental stresses. So we can't usually use the Gram stain to identify mycobacteria. We have to use a different technique. The acid-fast stain is also differential. Most bacteria will appear blue after following this technique, while Mycobacterium tuberculosis and a very small number of other species will be red, and these are considered to be acid-fast cells. They stay red after the decolorization step. Finding acid-fast bacteria in the sputum is considered definitive of somebody having active tuberculosis. There are also some molecular tests available, which are usually quite rapid. Some of these can be used to detect not only if the bacteria are present, but if a particular strain contains resistant genes to certain drugs. The overall death rate from tuberculosis is estimated to be around 4%. However, if the disease goes untreated, the death rate goes to around 50%. And we also see differences in how well treatments work depending on the infecting strain. we're starting to see more resistant strains of tuberculosis. Multiply drug resistant and extensively drug resistant strains are much more difficult to treat. And unfortunately, individuals with severely compromised immune systems also have lower cure rates. When treating tuberculosis, combination therapy is used, and this usually combines isoniazid with at least one other drug in treating active tuberculosis. The first-line drugs are preferred, and second-line drugs are only used if the strain is resistant to first-line drugs. The second-line drugs may be less effective than the first-line drugs, have worse side effects, or they might just be more difficult to obtain, particularly in developing countries. This is a very long treatment period. 6 months is usually the minimum, and it can end up being longer. I mentioned that the mycobacterial cell wall has mycolic acids, and this makes it unusual compared to most bacteria. Some of the drugs that are used are only effective against mycobacteria because they target components of the cell wall that are unique to them. And you'll note here that peptidoglycan in these cell walls is linked to arabinogalactan, which is linked to these mycolic acids. So here we've got our first-line drugs. Both isoniazid and ethambutol both target these unique parts of the cell wall, and this makes them extremely narrow-spectrum drugs. Pyrazinamide is only used in combination with other drugs and appears to interfere with the plasma membrane of the bacteria. Rifampin is a broader spectrum drug that interferes with the RNA production. MDR-TB, or multiply drug-resistant TB strains, are resistant to isoniazid and rifampin. This means that second-line drugs, such as the ones shown here, must be used in treatment. And unfortunately, it's possible that these MDR-TB strains can eventually end up developing resistance to some of these drugs as well. Extensively drug-resistant, or XDR-TB strains, are resistant to key drugs in the first and second-line regimens of treatment. Some of these strains are resistant to additional drugs on top of that, making these infections extremely difficult, or in some cases, impossible to treat. Don't concern yourself with memorizing all the details here, but keep in mind that there are different types of treatments depending on whether somebody's got active tuberculosis versus latent tuberculosis. And with latent TB, sometimes people are only treated with isoniazid, so we don't have combination therapy in some of these cases. With many bacterial infections, antibiotic treatment takes maybe a week or 2 weeks at the most, and typically only requires maybe 1 or 2 pills for each dose. Tuberculosis is a lot more challenging than that. In addition to having these very long time frames to complete the drug treatment, people may have to take multiple pills for each dose. Treatment often fails as a result of non-compliance, and one of the things that's now routinely done is something called DOT, which stands for Directly Observed Therapy or Treatment. This just means that somebody makes sure that a person actually takes their medications for tuberculosis. The WHO strongly backs this strategy, and their DOTS plan stands for Directly Observed Treatment Short Course, and focuses not only on this observation of people taking their meds, but other things that should really help control and cut down tuberculosis spread.